In our panel session on this Monday, we delve into Korea's Omicron outbreak, including its current trend and related response efforts. For more, I have Professor Kim Moon-gyu from Yonsei University. Professor Kim, it's good to have you here.
Great to be here again.
I also have Professor David Kwak joining this session virtually from the university, Suncheon University, that is. Professor Kwak, it's been a while. Welcome back.
Good afternoon, Sunny.
Right, Professor Kim, it appears that our daily tally is on a steady decline. Do you believe we're past our peak?
Well, I always look at the 7-day average per population data, and it took a peak on 17th of March, which was about 10 days before, to the point of 7,800 something per million, almost 8,000, and now it's about 6,800. So I think it's declining already for more than a week, and it is almost the same level of the peak of Denmark and a month ago. And if we follow the pattern of Denmark, I think we're going to see a decline for the rest of the time. But we have to look at other countries like UK, France, and Israel. They had a peak, and about 2 months later, they have a resurgence. And maybe it is because of this stealth Omicron, also called as BA2. And if we look at Hong Kong's data, they say about 90% of their COVID-19 is BA2. And this BA2 is about 40 to 50% more transmissible. So it's spreading very rapidly. If we look at the reproduction number, Omicron BA1 is about 8 or 9, but BA2, stealth Omicron, is about 12. If you have this kind of number, it's almost like an airborne disease. So it will infect everybody who didn't have this immunity. And Germany has about 50% of cases with BA2, and USA about 10%. But their death rate is almost same as Omicron, so it's low, thankfully. I think Korea is about 56%, so I think if we look at the data of the severe cases, I hope that it will not rise much. Vaccine efficacy is almost same, BA1, BA2, and if you have been infected with BA1, that means you may have a strong protection against BA2. So why do we have this kind of increase in those countries like Israel and something? I think they ease the social distancing. They are not wearing the mask so well, and they have more social mixing together. And I think many people were infected with previous variants such as Alpha, Beta, and Delta. So waning of immunity might be another factor, but I don't think that's going to be a problem for Korea because almost everybody is infected with Omicron and stealth Omicron.
Right. And Professor Kwak, despite the decline in Korea's daily tally, its numbers of critical cases and fatalities remain quite high, as my colleague Min Jung mentioned earlier. What should be done to better address this unfortunate scenario?
Well, we can only expect it to actually go even higher from this point on because it hasn't exactly been 2 weeks since the peak of the wave, which we are hoping that we're passing through. So we would, and this is just my personal opinion, that we would have to heavily focus on protecting those who are vulnerable. And I thought about this, how we can accomplish that. We're currently having about slightly less than 2 million of people or so currently contained in their homes being taken care at home treatment. But those include everybody who's been diagnosed with confirmation of COVID-19 cases. I think we may need to change that scheme and focus even more on only those who are more vulnerable, such as those who are elderly or who are with underlying diseases, because at the current state, the doctor who is responsible to take care of all the home treatment cared patients, they're pretty much taking care of all the patients regardless of their vulnerability to the disease. If we can sort of shift the scheme so that these same medical human resources can focus even better on those who are more vulnerable, I think we can probably take a more aggressive approach to minimize further happenings of severe cases and possibly death even. But also in that sense, I think it'll also be it might be an idea to designate certain hospitals to only take care of people who are more vulnerable, such as the elderlies. We currently have some spaces available throughout the hospitals nationwide, but if we are able to, let's say, designate more numerous hospitals to solely take care of even mildly infected patients who are vulnerable, I think we'll be able to sort of catch these people from abruptly falling severely ill among those who are more likely to have such cases. So for example, if a hospital was, let's say, taking care of anybody who's above 50 years of age instead of everybody who's having the disease, they'll be more likely to catch more numbers of more severe cases and whatnot. So I think, and then like once again, I iterate, this is only my personal opinion, but to minimize further deaths and further severe cases, I think we need to think about how we can focus our energy and our resources to only those who are vulnerable.
Right. And staying with you, Professor Kwok, Korea now has a second antiviral pill to fight COVID-19. What are your prospects with regard to the role of LAGUEVRIO in curbing Omicron, or critical cases, that is?
Well, both the medical pills that we are currently equipped with have its pros and cons. For example, molnupiravir, as we have talked about numerously, is limited in a sense that it only showed about 30% of efficacy in its preventing of deaths and severe cases. But it doesn't have as the side effects or the limitations that the Paxlovid has in that regard. It can also be given to patients who are concomitantly taking other types of medications that are metabolized through liver, as opposed to Paxlovid is kind of limited in a sense that it is limited only to the patients who are either not concurrently taking liver metabolized medication, or those people who that would have to stop taking their original medication while they start on the Paxlovid. So in that sense, because we have to sort of balance and match in its use of all people, addition of molnupiravir to the only equipment that we currently have, Paxlovid, I think will be a great addition. But because it also has its own limitations, it being carcinogenic for one, I think we have to expand our view and explore other types of alternative methods that we can also use to protect people. I think, for instance, as Dr. Coetzee mentioned a couple of weeks before on our show, starting to use corticosteroids much early on in its progress in the people will also help minimizing the symptoms. I don't think it'll help in preventing death rates or severity rates, as prior studies have proven so, but at least it could contain the symptoms minimally so that we could better focus on those people who are already with severe symptoms. Number two, we have to focus on the fact that these elderly generations who are more vulnerable to the disease can abruptly and quite suddenly fall ill even after being discharged from hospitals of their stay with COVID-19. So we have to, I think, extend the time of period where we have to keenly monitor these more vulnerable people. So instead of just monitoring them for 10 or 7 to 14 days that are currently as set, but we should keep maybe contacting them back to ask them if they're of their well-beings and whatnot, to check back on them to make sure that they don't suddenly fall ill from their prior COVID-19 infection.
Right, so frequent monitoring would be very important then. Also on the treatment front, Professor Kim, do tell us a bit about the differences in intensive management and general management with regard to care of COVID-19 patients.
Yeah, I think we have two categories: standard management and intensive management. The new indications for standard management group includes age over 60 and people with underlying condition. They used to just belong to an intensive management group. It is because we have more than 9,000 clinics or centers who can make a diagnosis with rapid antigen test. And if it's positive, they can prescribe the medications like Paxlovid and Molnupiravir. And people just can get the medication and start treatment early in the course, which is very good. So even though you're over 60, you don't have to go all the processes that was needed.
Right, so the protocols have been cut in short then.
Yes.
And how effective would this shift in strategy be to treat those in their 60s and those with pre-existing health conditions?
I would just want to explain what step they went through. If they had a positive results out of rapid antigen test, they have to visit a center or hospitals to confirm COVID-19 with PCR, and it takes time to have the results. And if it's positive, you might need time for arrangement. The transportation is not that easy because you need a specific ambulance to transport positive cases, and you have to call the center and they give you arrangement. And to get the medication takes also time. So you just lose about 2 or 3 days on this process, and some patients might get worse during those times. So private clinics should understand the whole process, the new process, and there's one condition. We can easily prescribe those medications in those 9,000 clinics. If it's not enough, this new strategy will not work out easily. And patients should follow the instructions correctly to be successful.
Right, I see. And Professor Kwak, do share with us some words of advice for COVID-19 patients under the standard care management, especially for those in their 60s and those with pre-existing health conditions.
Well, for the time being, I think people who are above 70 years of age or who are very young in their ages that are without guardians to monitor them are currently suggested to actually go to social distancing facilities and be monitored by the governmental human resources. So in that regard, I guess they are at better hands because somebody would have an eye on them to keep them safe and alive. But for those who aren't, and for those who think that they are being monitored but actually are quite distant from, let's say, the closest point of contact, let's remember that somebody needs to still check on them, whether if it's not from a medical sector, somebody of kind of closeness, such as a family member, should keep contacting them every hour or maybe every 2 hours to check back on them of their well-being. So I think it's important that they keep a certain point of contact that could notify the medical sector immediately in case there is something happens. But also at the same time, immunity matters. So when we talk about self-containment at homes, we usually imagine a situation where we're just confined in a room, not doing anything, really just self-distancing from everything else. But immunity really matters in this fight against this particular virus. So if you're going through very mild symptom, I think a certain level of activity, and I'm not talking about exercise, but a certain household activity would still be helpful, and also exposure to sunlight and also eating well are very important in maintaining all their immunity levels. So just some of the tips that I can think of in my head to those who are currently home contained.
Right. And moving forward, Professor Kim, authorities are also looking to scrap rapid antigen tests at screening centres and simply focus on offering PCR tests to those eligible. What are your thoughts on this?
Yeah, many times I emphasize that the rapid antigen test is meaningful only when it is positive. This morning I had a patient with chronic kidney disease. He's a small child and has to go on dialysis. And about a week ago, his brother was positive with rapid antigen test, but the patient was negative yesterday. So he called us then whether to come or not. I told him just come, and I led him to the emergency room, and then he's on the PCR result right now. But if he's positive and he got the result at home, he needed a special ambulance to transport to hospital. So I had better him stay at the hospital. So if you are positive at home, you don't need more PCR. You just can visit the clinic, just as I told you, for prescription. And the health centers may focus more on PCR and other things. I think in USA there's a financial resource issue. You know, we spent a lot of fund during those 2 years, and I think it's the same situation in Korea, also in the manpower. So I think it's good to move on PCR and other areas to focus on.
Right. Meanwhile, on the vaccination front, Professor Kwak, it appears that Korea's booster uptake has been hovering little changed on the 60% level. What do you suppose can be done to boost it further?
Well, in that regard, I think the government has to come out clear about what's happening with its booster rate and among what age groups are showing higher incidences of infection. As you can clearly see, we saw in the past a few weeks or so a steep rise in the infections among very younger generations. And those happen to be also those ones who are not completely vaccinated at the point. It just makes sense. Obviously, these vaccinations is not going to protect you from getting an infection, but it still works. It still works in the larger numbers. And also, for those who are injected, they clearly clinically show less severity when they are actually infected. So I think the government, whether it is beneficial to their image or not, has to come out clear and show the people what these vaccinations are clearly doing among different groups of generations, among their own death rate, severity rates, and even just in an infection.
Right. Professor Kim, with regard to inoculation, let's imagine that a partially vaccinated person gets COVID-19 before his or her second shot. Should this person receive his or her final shot after recovery?
Well, I wish I can say that if somebody is infected, you are free of vaccination, you don't need anything anymore. I wish I can say that, but it's not that simple. From the commentation from WHO, they say that people who already got COVID-19 have a higher chance to infection compared to people who recovered and had vaccination. So even though you recover from COVID-19, you still need a vaccination because it's about 2.3 times higher to get infected. So we regard that infection as one dose of vaccination. So if you get a first vaccination infected, then you need a booster. And it takes about 3 months after the infection to get the vaccination. I mean, if you get vaccine too early, that vaccine might not be so effective. The antibody remains in the body for 5 to 6 months. So we need more research on the timing of those vaccinations, especially for Omicron. It might have a different picture compared to previous mutants. So we have to wait for that, about the timing, when, and what we're going to do with Omicron.
Right, I see. And finally, Professor Kwak, very briefly speaking, for those who have recovered from COVID-19, what are some persisting symptoms that they should be wary of?
Well, the most common symptoms we are currently seeing are those people with lung symptoms, so those with breathlessness. But we're also occasionally seeing people with chest pain. And very commonly, we are seeing patients with fatigue and very tiresome daily activities and so on. So these are what we call long COVID syndromes. And for those people, especially with chest pain or breathlessness, I strongly suggest that they be checked out at a medical center just to make sure that they're not having it in any severe forms of long COVID-19. But most other things, I think, will generally fade away within about 2 months or so.
Right, that is good to know. All right, Professor Kwak, as always, thank you very much for your thoughts. Professor Kim here in the studio, thank you for your insights.
Thank you.